All right, and we're on. So I'm Dr. Randall Gates. I am a chiropractor, as well as being a board-certified chiropractic neurologist. This is
what we're on. So I'm Dr. Martin Rutherford. I am a certified functional medicine practitioner, and today we're going to talk about subclinical hypothyroidism. And you caught me moving this because I use that as a reference, and the light is shining right on it, and I couldn't see it. But we're going to talk about subclinical hypothyroidism today, which is probably one of the more important subjects that we're going to talk about because we see it all the time. It is mind-numbingly misunderstood. Mm-hmm. Thyroid problems are so common out there. Dr. Gates is conversant not only in the functional medicine aspects of what we do in the nutritional aspects, but his expertise is largely in brain and nervous system and
we won't say expertise. We can't use that word here in Nevada.
Okay. Yeah. So he knows a little bit.
My area of focus.
He knows a little bit about the brain and the nervous system. Yeah. And as a board certified functional medicine doctor, I've gone through courses that talk about all of the things that are now becoming commonly understood out there about inflammation and PCOS and leaky guts and all these different things that are now becoming aware. But we have melded those two disciplines into a common practice because we found that it's the most effective way to take care of a lot of the chronic pain and chronic diseases that have developed in the society today, because they're very complex and they require a very precise and very comprehensive overview that includes both the nervous system as well as the endocrine system and the immunology system and the gastrointestinal system. So we've developed this chronic pain practice essentially.
Right, and I want to impart something too. And so early in the evolution, we were doing a lot of neurology-based illnesses, dizziness and vertigo, peripheral neuropathy, fibromyalgia primarily, and we still do. But what we saw early on was the prevalence of thyroid disorders, autoimmune issues. Sorry, I didn't want to cut off, cool. But then Dr. Rutherford, his focus is on functional medicine. You're a certified functional medicine practitioner. Right. You're one of two in Nevada that we know of who's certified to that extent. I'm the only board certified chiropractic neurologist in Northern Nevada. I think there's one in Southern Nevada and Las Vegas. But we've melded our two disciplines to handle the chronic pain, chronic disease patient from a metabolic side or nutritional side, which we'll explain in more detail, as well as the brain-based aspect.
Right. As we started getting into the neurological issues and as we started getting into chronic pain and chronic conditions in general, we started realizing that there were a few consistent things that were going on with most of the patients, and then there was a bunch of other things that varied, and the consistency was stress mechanisms. The consistency was the now becoming very understood gut problem, although that's a lot more complex than it's being presented out there. And then this massive underlying population of subclinical hypothyroidism. For us, we understand it even more as kind of like a subclinical autoimmune problem, right? And so this is big. This is big for any of you who are watching this because of subclinical hypothyroidism diagnosis. This might be an eye-opener for you. For us, it is enormously helpful to understand what we're about to impart to you because it is a key for our Hashimoto's patients. It's a key for our fibro patients. It's a key for a percentage of our peripheral neuropathy patients. Dizziness, vertigo, balance. Absolutely. A lot of those people come in telling us they have depression. A lot of them come in telling us they have many of the things that we're going to be talking about, but they didn't come in for those. They didn't come in for cardiovascular problems, or they didn't come in because they couldn't have a child or anything like that. So this is a big, big deal. So I just kind of gave a brief overview of what we're going to go over, and let's get going on it because it's funny. I never thought I'd be one of these guys sitting here doing this like intellectual academic stuff. This is really exciting because I'm kind of a normal guy outside of this, but this is really exciting. This is a really exciting topic. I hope that we topicked it correctly online so that people will actually look it up and come to this site. If you don't look at any of our 150 hours of stuff or however many hours we got, this is this is going to be a very valuable few minutes if you decide to watch through this. So subclinical hypothyroidism versus normal, or as you term it, overt hypothyroidism. I'm taking overt hypothyroidism as your TSH is up, you take the levothyroxine, and everything goes away.
Well, in the literature, the way they describe overt hypothyroidism is where you have elevated TSH, but then you also have low thyroxine or T4.
Yeah, okay.
So that's overt, whereas subclinical originally was defined as an elevated TSH with normal T4 levels.
Okay. And I don't think it would be to take a few seconds and talk about what TSH and T4 and T3 is, just simply because I get that a lot in the consultations. They know their TSH, but they don't really get any of it. Like what? And the fact is that most of them only get a TSH. Seems like a little larger handful of people are now starting to get a T4 consistently.
Right.
Rarely do they get a T3. So.
And because basically the TSH is a hormone that comes from the brain telling the thyroid to work. And then T4 is the hormone that the thyroid produces. And those are the major lab markers, as Dr. Rutherford is describing, that you'll see on your lab test. There's also something called T3, which T4 gets converted into, and T3 is the active form of thyroid hormone. Most of that conversion happens in the gastrointestinal tract and the liver. But basically, the thyroid produces inactive thyroid hormone. Now, T4 and T3 feed back to the brain to tell the brain, where are we at in terms of our thyroid hormone levels? Very much like a thermostat. If it gets too hot in the house, your furnace turns off. Same process in the body. So the brain is getting these constant signals, and it's knowing what the levels of these thyroid hormones are in the bloodstream. So it can tell the thyroid to either increase its activity, saying stimulate it, thyroid stimulating hormone, or slow it down, less thyroid stimulating hormone.
Okay. So subclinical versus over. So it's a matter of, for your doctor, okay, for your allopathic doctor, it's a matter of looking at your lab markers. And so you can't, and they're talking almost, well, they're not, they're talking about your thyroid stimulating hormone, and they're talking about your T4. And if you are sitting there and you've taken your levothyroxine and you've been told you have a hypothyroid and you're not doing well with it, part of the reason might be that they're just looking at your TSH and trying to dose you on that. Part of the reason might be they may not be looking at your T4, or they might be looking at you and calling you a subclinical hypothyroid, which the Mayo Clinic calls mild thyroid failure.
That's a good way to describe it.
Mild thyroid.
It's one way to describe it. Maybe that's one way to say it. And really, the discrepancy has come from what the upper value of the TSH should be. So medical doctors trained in your era were taught, you don't treat.
In my era. I'm twice as
your age demographic.
I'm twice as age.
We're often taught that you don't treat the thyroid unless the TSH is above 10. That value has come down consistently through time. And then we were just talking, I think it was either 2012 or 2013, one of the endocrine societies came out and said anything over 3.7 requires treatment. And that really stirred the talk in terms of subclinical hypothyroidism, because now we have all these people out there who have a TSH of 3.9 or 4.1. And now medical doctors are kind of getting these messages from these societies saying you should treat this person, even though their thyroxine or their T4 levels are normal.
So if you feel like your medical doctor is not conversant with this or is confused about it, it's not that they are particularly confused about it, it's that
the societies are still a little confused.
That are very confused about it. In fact, the Mayo Clinic is very adamant that they have not figured this out yet. And I might even give you a quote from that. But doesn't this go? So this goes a little bit farther into the fact that, and again, I did a little review of the Mayo Clinic this morning. Patients, well, not all I can. Well, we had a lot of patients coming to go, Mayo Clinic said this. I went to the Mayo Clinic. The Mayo Clinic said that. They did a study that detected high thyroid antibodies in 80% of the people that they had diagnosed with subclinical hypothyroidism.
That's beautiful. I love it. I love it.
This is like the first time I ever told him something he didn't know.
I have not seen that study.
This is our research. This is our research department right here. Okay.
Because we had seen LabCorp come out and say
online
overt hypothyroidism, 95% had antibodies.
I was saving this.
I know, right?
I wanted to see
This is a golden moment.
But yeah, 80%.
We should have a moment of silence.
Because this is very important. This is very, very important.
Right.
Describe antibodies.
Absolutely.
Okay.
So antibodies to the thyroid, they're immune cells. So way back when 1960s, a lot of people started coming out with these goiters where the thyroid was enlarged. And
my mother, my aunt, my grandma.
And at that time, the consensus was that these goiters were due to iodine deficiency. And there were iodine deficiencies at that point.
Right.
Since then, we have iodized our salt, and most of us do not have an iodine deficiency living here in the United States.
I think you need the amount of iodine that fits on the pin at the head of a needle, like for a year, to have enough iodine in your thyroid.
It's pretty small.
So we get it.
It's infinitesimal.
Yeah, we get it.
So then the question became, well, why do all these people have hypothyroidism? And the number seems to be growing. That's what a lot of people are saying. And in essence, that's where researchers in endocrinology started realizing that the immune system is killing the thyroid as the cause. And as we just said, 95% of overt hypothyroid patients have been demonstrated to have this autoimmune response to the thyroid called Hashimoto's thyroiditis. That came from LabCorp in a piece of literature they gave us. Other estimates range between 90 and 95%. But then for you to say for subclinical hypothyroidism,
right.
Mayo Clinic coming out saying they're seeing at 80%, it's very significant. So
it was 350 people. It was pretty good.
Good
study.
Sample size.
Yeah.
And so now we're seeing, okay, so the immune system is really the culprit behind all these disorders.
Right.
And
therein lies the issue. And we just had last night. We just had that lady who was in here, and she's got an autoimmune problem, and she's got an autoimmune attack against her thyroid, and we sent her back to her medical doctor with a very nice report and a very gracious letter, and she was attacked. I guess we were kind of attacked in the.
When she was told that all of her problems came from smoking,
and she does smoke, but all of her problems were coming from this. So subclinical hypothyroidism in the medical world is still I don't mean to just go to one website, but I thought I would go to a website that people understand is people can communicate with the Mayo Clinic. They essentially, in a very nice way and very prosaic and very articulate way, said, we need to figure this out because we don't know what the heck's going on here. And there's a huge population. I mean, I wouldn't want to be an endocrinologist doing thyroid today because they're utilizing this method. And their method is if you have a TSH over 10, levothyroxine will help. If you have a TSH still to this day, between 4.1 and 10, it's very controversial as to whether your levothyroxine will work, which is most of our patients.
Right.
However, at least 80%, according to their study, have autoimmune antibodies. So in my world, all right, and in Dr. Gates, but when I say my world, like in the functional medicine world, that's actually technically in my tweaked thinking, technically, that's not a thyroid problem. Technically, it's an autoimmune problem. They have and realized it's an autoimmune problem. And in the way that it was written, just basically kind of blew right through it. Mm-hmm. Kind of like, well, and they also have antibodies. That's the problem, folks. And that is the exciting part of this. I mean, those of you who are out there trying to get your medication right and your poor doctors trying to get your medication, this is the data that they're working from.
Right.
And that's why there's a massive group of people running around out there with Hashimoto's, thyroiditis who have not been diagnosed with it. Those who have been diagnosed with it are being treated with levothyroxine, right. or experimenting, or experimenting with Synthroid or the other things. They're trying to put the cytomel on.
Well, that's a great example because people can have Hashimoto's thyroiditis where their immune system's killing the thyroid and their TSH may not be off yet.
Yeah,
it may never be off, but then it may be off too. And so
you might have normal findings.
Right. And that's where this whole area of subclinical hypothyroidism is so interesting because now we have these 4.1 to 10 range on the TSH, and what do you do with them?
Well, and I read that website this morning, and here's what they said. Here's what they said. Here was the conclusion of the Mayo Clinic on subclinical hypothyroidism. a large-scale government I can't even say that. A large-scale government-sponsored, why government, I don't know, multi-centered, randomized, placebo-controlled study is urgently needed to assess the efficiency of using levothyroxine therapy in a subgroup of TSH levels less than 10, which is most people who have subclinical hypothyroidism. So as of today, this is where the medical society is. These are the most advanced diagnosticians in the medical world, which means they may not get to figuring out that the autoimmune system is the actual battle for years, because clearly this is designed to find a drug.
Right.
And we're not anti-drug.
And how do we use the drug?
And how do we use the drug, and how's that going to work? And I mean, this is what we do. So we're going to kind of go through that with you a little bit, because there is an answer. But we'd like to bring you a little bit more of a real understanding of what you might be facing if you're messing around with your medications and nothing's working. Consequences may be occurring in your system. And that was what it looks like you wanted to emphasize today.
Exactly.
So why don't we go ahead and do that?
Yeah, absolutely. And there's one other thing I wanted to say, because so often we have these patients who come in.
I think I threw them off because I knew that. This is an inside joke. No, you'd have to know. Dr. Gates probably does 20 hours of research a week, and I probably do none. Okay. I mean, he probably does more research in a week than I do in a year. And he has been a tremendous, tremendous addition to our ability to take care of these things. So I just thought I'd hold that out on him.
I love it. I love
it. I do all the consults here. I try to determine who are good candidates for our protocol. I'm in on the exams, but essentially Dr. Gates does 100% of the treatment now. And so he's always researching. And so I think we're pretty much in or ahead of the curve relative to what's going on out there. Right. And we'd like to share that with you.
Exactly.
We'd like to share that with
and
you.
So many patients come in saying, well, I've been diagnosed with my thyroid's borderline low. That's you out there. TSH 4.1 or 3.7 to 10. Lots of times you're being told that. And again,
you don't need to be treated yet. Let's just wait. That's another one. Exactly. Well, my doctor told me, let's just wait. Let's tell you what might be happening while you're waiting. Well, that's what you wanted to do.
Absolutely. So basically,
we didn't meet on this one, okay? You might have been able to tell by the opening when I was fumbling around here. But.
Yes, cardiovascular side effects have been demonstrated. So for you out there worried about your heart, you're looking at your cholesterol, maybe you have a family history of heart disease, subclinical hypothyroidism irrefutably now has been associated with calcification, increased risk of cardiovascular events. Reason probably why is that when you have a hypothyroid situation, everything kind of slows down. So cholesterol tends to go up too. That's something that's talked about relative to this whole process. So yeah, I mean, it doesn't really get more life-threatening than that.
Myocardial infarcts.
Exactly.
And atherosclerosis and the things that you hear about all day that are, the medical community does seem to be grasping onto the connection between thyroid and the cholesterol.
That is true.
But is still going at it
right
from the perspective of giving levothyroxine. Are we going to go over what the answer is in the end?
Yes, we will.
Okay. All right. Let's do it that way then, because we're going to tell you how to go about this. Okay. Because virtually all of you actually have an autoimmune problem that is attacking your thyroid, and levothyroxine might help for a short period of time. In some cases, it's really going to help long-term if you have subclinical hypothyroidism and you have the antibodies. So again, pregnancy.
Yeah. So this has been a more debatable feature. So we'll tell you, like, cardiovascular events, irrefutable. That has come out. So there's no discrepancy in the literature about that. Pregnancy, most obstetricians now who are up in the literature are leaning towards subclinical hypothyroidism affecting the female in a deleterious fashion. Mm-hmm. So in a negative fashion, if that thyroid is not treated, it can cause miscarriages, it can cause unwanted side effects to the newborn fetus. So that is now becoming more agreed upon. And the same thing with Hashimoto's thyroid. Hashimoto's was a little more tenuous, but now the literature is starting to say that is an issue too for these pregnant females that needs to be addressed.
And again, if we didn't make it clear, Hashimoto's is the term for a thyroid that's being attacked by your immune system. So when I said technically it's not a thyroid problem, it's an attack on your thyroid. I should have used the term Hashimoto's. And to tag on to that, there was a couple of studies attached to the Mayo Clinic website that said that the child will suffer and may have as much as a 7 to 10 to 20 point drop in
IQ. Yeah, exactly.
Yeah,
they're a little slower.
Yeah.
Which is kind of
interesting. So if you're young and like the lady I had in here the other day was 19 years old and her TSH was off just a little bit. She's put on 25 pounds. She has all the classic hypothyroid symptoms, but it wasn't enough to give her medication in her doctors. And she's of childbearing age, and she's going to college, and she can't study right now. And we'll probably get into that.
Yeah.
So you wanted to talk about fasting versus postprandial thyroid stimulating hormone.
Yeah, which is interesting. So basically, if you get your TSH tested when you're fasting, it's more likely to be a true representation of what is happening with your TSH versus after you eat. Lots of times the TSH will go down. And TSH, most of the time, in and of itself. So
I didn't know that.
I didn't either, frankly.
I didn't know that.
Because we always send people for, hey, just go over to the lab right now, get your TSH done.
Exactly.
And that can make the difference. So, hey, if you're at 3.2 most of the time, when you're eating.
Unfortunately, our first tests are always
exactly
fasting.
But my repeat tests
are not.
And so basically that can be the difference between you getting an accurate diagnosis or not.
So that's a perfect example of where the science is. And we're just talking to you like we sit and talk at breakfast on Saturday morning. Mm-hmm. Or at any other time that we sit and talk about these cases and the research that Dr. Gates comes up. This is a highly evolving solution, or a highly evolving situation, as represented by the Mayo Clinic saying, we need this big urgent study done that's going to take like 15 years probably to try to come up with a medication. Because in reality, if you want to know why your doctors don't seem to have more certainty on this, this is why. If the Mayo Clinic doesn't have certainty on it, and they haven't, and they're basically saying they haven't figured it out yet, what are the chances of your doctor? Where are they getting their data from? So this is another little step forward in managing a case, because Amen. Dr. Gates manages a case very closely, and he will do those TSHs sometimes on a weekly basis. Mm-hmm. And now he finds out that he can get it a little bit clearer. He can get a little bit more precise. And believe me, a little bit more precise in this area is significant. It's very significant.
And when you and I first started working together, you used the analogy of a pontoon boat. So lots of times mainstream medicine is like an oil tanker. It takes them a while to make a change because they need these big studies. These studies take time. The government funding takes time for it to come through. Whereas we're looking at, okay, what's the most up-to-date literature and how can we make a change that's going to help that person now, rather than 4 years from now when they had a heart attack.
And the reason we can do that is because we're not going to do anything that's going to hurt anybody. It's either going to work or it's not going to work, but it's not anything that's going to be detrimental to their health.
Yeah, exactly. And, we'll communicate to your doctor. We'll write letters. We'll say, okay, this is the most up-to-date literature. We'll attach references. That's why there's 27 references attached to this.
What idiots we are.
We get that rarely.
Well, the patient's getting better.
Yeah,
we do get that rarely. We didn't used to get that rarely, but now we actually have a pretty good relationship with the local. We're in Reno, so with the local medical community, we do. Well, we do. Mm-hmm. So we talked about pregnancy. We talked about maybe the fetus, but fertility and polycystic ovarian syndrome. We see a lot of this. It's kind of next on Dr. Gates' hit list here. So why don't we talk about that?
Yeah, polycystic ovarian syndrome.
This is significant.
Major issues for all you females out there who may have abnormal menstrual cycle lengths. 28 days, 1 month, 35, the next 45, and 10. And then you may have cysts on your ovaries, or you may have too much testosterone. 2 out of those 3 will qualify you for having polycystic ovarian syndrome. PCOS is really significant because upwards of 20% of females have PCOS.
Yeah.
20%, which is just ridiculous. And lots of times they struggle with gaining weight. They can't lose weight. They get unwanted hair growth in areas where you don't want them as a female, like the face or the chest. And also, PCOS patients have a hard time getting pregnant. So the literature is now coming out showing that upwards of almost 50%, 43% in this one research study we looked at, have Hashimoto's thyroiditis, who have PCOS. And then they also said that subclinical hypothyroidism is a very significant entity and needs to be addressed in PCOS patients. And that was a pretty recent study. I think it was out this year. And so those two go hand in hand. And basically, we've done whole talks on PCOS.
Yeah,
And really,
like 45 minutes.
I knew I should have got cash. Damn it. We're good?
We can go back on.
Okay.
Okay, so we're back on. Sounds like something crashed or whatever, but what I was getting to was, I think we're getting to what I find in the consults of new patients that come in is really one of the more significant issues, and you're getting to want to get into depression.
Yes.
I mean,
major.
Everybody comes in here for something, but it is extremely rare that somebody comes in here for depression. But virtually every one of our patients has been diagnosed with depression.
And in the literature, again, this is one of those things relative to subclinical hypothyroidism. This is why the Mayo Clinic is saying we need this big study, because some reports came out early on saying we don't think subclinical hypothyroidism affects depression. Now there are other studies. The one we attached is from the Journal of Nervous System and Mental Disorders, where they said, yes, it is. And keep in mind with these studies, lots of times you have to really read the study and look at, okay, what are their criteria? So a TSH maybe above 7 is their criteria for saying subclinical hypothyroidism doesn't have an impact, or maybe it's above 3.7. And so you have to take all these studies with a grain of salt. You know, and that's hard for the lay person out there, but that it is associated with depression. Dr. Robert Sapolsky from Stanford University, he is a world-renowned neuroscientist. Primarily, he's done research on the effects of stress in the human nervous system, but he's also done a lot of research on depression as well as other mental disorders and their relationships to the immune system. But interestingly enough, he talks on depression to a lay public at Stanford, and he demonstrated that subclinical hypothyroidism, Hashimoto's thyroiditis, as well as stress hormone alterations are major things you have to look at for someone who is depressed. Because we can give depressed patients medications to replace maybe those neurotransmitters like serotonin in the brain. But lots of times those effects, which are really good early on, can start to dissipate through time. So a person has to go on more antidepressants, have to go on multiple antidepressants. Whereas if we look at the true cause of what's going on, we look at the thyroid acutely, when we look at the stress levels, and we look at the immune system and how it's affecting the thyroid. Because another thing that is discussed is that when we have this autoimmune response to the thyroid, that immune inflammation can go into the brain. So it's very analogous to being sick all the time. So when we're sick, we get a cold, we just don't feel so good. We don't feel as confident. Well, that may be happening at a low level in these depressed patients.
Yeah, and the latest literature also shows, allopathic literature, whatever, shows that it can be contributing to bipolar disease and cognitive function. Now, in our world, in the functional world, I must tell you, we do not look at depression, cognitive function. I'm not too sure about bipolar disease, but anxiety, these types of things, we don't look at them as a social or personality disorder for the most part. We understand that there are pathological contributors that are possible, and in our particular clinic, we do an extremely thorough exam, and normally doing a thorough neurological exam, and we have a fairly long history that we have people fill out. It's like a 17-page check sheet. By the time we've been through that, if it looks like there's some pathological problem, usually it's going to show up and it'll be referred properly. However, most of our patients do not have that. Most of our patients are having either subclinical hypothyroid problems, or in my world, Hashimoto's thyroiditis problems, or they're having just a direct thyroid hit on their brain, which can cause depression, or they're having inflammation from their gut, or they're having too much cortisol from adrenal stress. There's so many different pathways that can affect brain function, and because this has developed so much over a period of time, that all these chronic pain problems and all these chronic illnesses are developing, it's become obvious in our clinic from the clinical reactions to the treatments that are done, that for the most part, these either go away or improve substantially without drugs.
In the properly selected patients.
In the properly selected patients, exactly. So this is a very big, I think this is a very big thing for people to understand, because when people come in and we do try to properly select them, they're very frequently concerned that their depression or their anxiety is going to stop them from being accepted as a patient. And then to be able to kind of turn that around and say, look, you're not crazy, you're not weak, you don't need to pull up your bootstraps. All of these things you have marked down here are probably either causing or vastly contributing to that. And there's a chance that once we get through the protocols here, that's going to reduce or disappear.
Right.
And it's a big shock.
Yeah.
That's a big shock for them. A pleasant shock, but nevertheless a big shock.
Well, it's interesting, you know, we talked about earlier, you know, there's this one medical doctor who maybe denigrated what we were telling the patient. But overall, as we said, we have a pretty good relationship with the medical community.
We do.
Actually,
we communicate
it's rather, really, really good. But we were at a conference. One of our mentors, who's a medical doctor, Dr. Vasquez, aside from being a chiropractor and a naturopath, he talked about when he went through one of his psychiatric rotations, that really the way it's gone is that it's now neuropsychopharmacology. So they look at depression. Okay, what medication can we give the person? We have a close colleague here in Reno, who I won't mention his name, but he's a psychiatrist, and he has really put his hands on functional medicine. He's gone through all the courses now because he sees functional medicine as a tool to explain why a lot of people have exactly as what Dr. Rutherford said, in terms of why they have depression, why they have anxiety, why they have these issues, because the subclinical inflammation can be causing these things. And we talked about a study a few weeks ago relative to depression. 50% have antibodies to serotonin.
Autoimmune problem.
Yeah.
This autoimmune problem, I call it a subclinical autoimmune problem. I don't know if that's actually a correct term, but this autoimmune problem that Mayo Clinic knows is there, but is not getting that that's the problem. We chatted before we got on. I said, why? I don't get it. I don't get it. We have patients that come in here who have rheumatoid arthritis, but they have all this other stuff. They have the fibromyalgia and they have the Hashimoto's thyroiditis. And
Thyroiditis. Where the person has a normal thyroid at that point.
normal thyroid. So you go to the doctor, you have every symptom that there is, and he tells you your thyroid tests are
exactly. But then if they run your antibodies to your thyroid, then they see that you have these large antibody counts to the thyroid, which this can be seen in upwards of 15% of the female population. 15% at a very high level, and we estimate that probably another 15% are affected at a more subclinical level, if you want to say it, since we're using that term. But in essence, the three causes of Hashimoto's thyroiditis discussed are stress, so cortisol, hormone fluctuations, food intolerances, so basically your immune system starts attacking certain foods. Those foods look like the thyroid, then guess what? Your immune system starts attacking the thyroid, and this can be secondary to what is now being discussed as leaky gut syndrome in the functional literature. And then also viral infections in the thyroid itself, which is a really, really neat finding. So now they're showing that in certain studies, upwards of 80% of Hashimoto's thyroiditis patients can have a virus living in the thyroid. And the immune system may be attacking the thyroid, trying to get to the virus. So now you have these three factors that really have to be addressed, and they're not really that simple in our clinical observation. We think that for example, the studies coming out on certain foods will be vastly more in depth in the next 10 years, and it's going to show other foods. And our mentor, Dr. Karazian, or your mentor, he is actually doing a study right now where he's looking at, I think, upwards of 30 foods that may be similar from a molecular standpoint to the thyroid involved in this Hashimoto's process. He's doing that with Dr. Vajdani, a renowned immunologist. So again, we're kind of on the front of the wave here, and we don't know everything yet, but what we do know, and then what we see clinically, we try to relay to you in these videos so that you have an idea that you're not crazy if you have subclinical hypothyroidism and you're depressed and you have heart disease and you're wanting to get pregnant. So
yeah. So hopefully that gives you some sort of again, I always try to walk the line between, we're trying to reach the lay public. I've occasionally gotten a little feedback from some of the doctors and physicians out there who want to know more. And if you want to know more, you got to do what we did, frankly. You have to either go to the courses and there's so much more out there than when I started. Oh my God. I mean, this is like night and day from when I started in functional medicine, but it's a very comprehensive discipline, is functional neurology, and they cross very nicely. They actually interlock very nicely because in this fashion, when we evaluate between the two of us, we're able to look at brain function, stress function, we're able to look at gut function, autoimmune function, the whole thing all at once. But so if you're a professional, that's kind of what you need to do. There's a lot of stuff online, but if we're trying to get to the layperson, we hope that we're articulating enough so that we're trying to talk to the person who has this and who has been through what all of our patients have been through. You're the person who comes and sits in front of me and says, here's my thyroid. And you got like, your stack of thyroid, and it's up or it's normal or it's down or they've only done a TSH, or maybe they've done a TSH and T4. And there's a lot more to thyroid than even what we just got done talking about. And but if you are having that type of a thyroid issue where your doctor can't figure out your dosage, or you have normal thyroid stimulating hormone, but you have every symptom that there is, and if you're in that category, or you've been told you have Hashimoto's, but they're still, because somebody bothered to run the antibodies, but they're still using thyroid levothyroxine on you, and you're still maybe felt a little bit better, you got a little bit more energy, or you're going to an alternative practitioner and they're giving you adrenal supplement, and you feel a little bit better for a little while or whatever. This is what you have. The chances of you having this is substantial. And so I hope that this gave you some sort of a kind of maybe a relief that you're not crazy, first of all. And secondly, that there are methods out there for you, and there are things that can be done. So if you have any questions on this, please feel free to contact us at powerhealthtalk.com. And I think Facebook,
you can also send to our Facebook page, yeah.
We're on YouTube. And any of the subjects that we talked about today, polycystic ovarian syndrome, Hashimoto's, thyroid, metabolic syndrome. I don't know if we've done one on depression, but most of those are online, and many of them are about this time frame. Some are an hour, some are 20 minutes, some are 40 minutes. So feel free to access those and get as much data as you can, and we'll go from there.
Beautiful. Okay. Yeah, and thank you for watching.
Okay. Thank you.